newly diagnosed multiple myeloma is a sort of a field that's just kind of exploding at this time. We have so many different treatments that have been studied in the relapse refractory setting that are finally kind of making their way towards the newly diagnosed patient. So how to best use them, how to best combine them is an ongoing process that will go on for many years. But the main thing with when a patient is diagnosed with multiple myeloma is deciding whether they are a transplant candidate or not. And so that actually has been a very difficult question to answer, and there's differences of opinion here and there, but ultimately we all have a way to decide who is transplant eligible and who is transplant ineligible. In the transplant ineligible patients, I think the treatment paradigms from the past were relatively poor. Those patients were felt to be frail, and they often were treated with less aggressively than they probably could have been treated. And so I think we're starting to see that there is a benefit in those patients to combination therapies than sort of the older and doublet or less agent-driven combinations. So I think what we've seen and what we see at ASH and this year, last year, in different meetings is that we're realizing that the standard treatments of old, the VMPs and the Lendex doublets, maybe are not the best for the patients, and so those are probably the biggest advances in the incorporation of the monoclonal antibodies, in particular daratumumab in this case, for both of those regimens, has added very little toxicity, but has significantly improved the outcomes of these patients. Obviously, we need longer-term data to fully assess it, but it's looking very promising.